Hi. Good evening, everyone. My name is Dr. Cindy Russell, and I'm president of the Santa Clara County Medical Association. I'd like to welcome you to the fourth session of the Diversity and Inclusion Series, webinar series, Health Equity, Resilience, and Leadership in a Time of Crisis with pediatrician Dr. Rhea Boyd. Dr. Rhea Boyd. She's been committed to writing about and advocating on this topic for many years, and we're very honored to have her speak tonight. I'd like to thank the Bay Area Medical Society Coalition, who sponsored this series, and give a special thanks to April Becerra, the CEO of the Santa Clara County Medical Association, as well as the entire SCCMA staff who initiated this series and worked very hard to bring this conference to you tonight. As all of you who are attending now know, this is a very important, timely, and consequential topic. The goal of this series is to promote critical conversations that provide a shared understanding on this subject. The hope is that this will transform into meaningful action around the issue of racism and the multiple issues causing health disparities. Representative Anna Eshoo, who introduced the congressional hearing on healthcare inequality this year with Dr. Boyd presenting, correctly identified this issue as caused by, quote, the plague of racism. I've heard Dr. Boyd speak before and very much look forward to hearing her thoughts tonight, especially about efforts to address this moving forward. Dr. Boyd has a particular focus on child and public health impacts of police exposures. She works at Palo Alto Medical Foundation and serves as a chief medical officer of San Diego 211, a program working with navigators to address social needs of San Diegans impacted by chronic illness and poverty. She's also director of equity and justice for the California Children's Trust, an initiative to advance mental health access to children and youth across California. Dr. Boyd graduated cum laude with a BA in African Studies and Health from the University of Notre Dame. She earned her MD at Vanderbilt University School of Medicine and completed her pediatric residency at University of California, San Francisco. In 2017, Dr. Boyd graduated from the Commonwealth Fund Mongan Minority Health Policy Fellowship at Harvard University School of Public Health, earning an MPH. I want to remind everybody, please type your questions into the Q&A box, and if you'd like to speak, please click on the raise hand button and we will unmute you. We provided a copy of the presentation slides for you to download in the chat box. And without further ado, I'd like to pass it off to Dr. Boyd.
Hi, thank you so much, Dr. Russell, for that beautiful introduction. Hi, everyone. Let me just share my screen before we start. We'll bring that over there. Okay, excellent. Today we're going to talk about actually the intersection between the pandemic and what we're seeing emerging in our country around policing and police violence in particular as two forms of violence, some physical, some structural, that are ensnaring many of our lives and shortening Black folks' lives in particular. I left my Twitter handle at the bottom of this slide, so if folks want to reach out to me, that's an easy way. I don't have any disclosures. So let's jump in. So in our country, inequality is growing, and our state of California leads the way, where the gap between the top 1% earners and the bottom 80% is widening. Part of that is because wage stagnation is profound in the United States. If you look at hourly earnings for non-supervisory employees, folks who are not the boss, they are making the exact same as they were in 1973. As a result, the purchasing power of our workforce has barely budged in the last 50 years. And so the reality is we are part of a generation for whom only half of our children will out-earn their parents. This is an aberration over the last half a century. And economic mobility is profoundly shaped by race and gender in this country. This is a map from research by Raj Chetty, who used to be at Stanford but is now at Harvard, looking at economic mobility intergenerationally by race and gender in this country. If you look at the green map on the right, it shows that it essentially pays to be a white boy who grows up to be a white man in the United States. Because no matter where he lives, he is likely to earn more in adulthood than his parents did when he was a child. Conversely, if you look at the red and orange map, you see that there's nowhere safe to be a little Black boy who grows up to be a Black man in America. because no matter where he lives, he is likely to earn less in adulthood than his parents did when he was a child. As the researcher summarized, in 99% of neighborhoods across the country, Black boys will earn less in adulthood than white boys, despite growing up in families with comparable incomes. When I often present this data, people say, oh, well, I'm not really surprised that white boys are faring differently than Black boys because of the history of racism in this country. And this is where this data is actually really fascinating and important. The researchers held constant a number of exposures to racism that we often think of. So this gap in economic mobility is the same for Black and white children who grow up with two parents in their homes. Their homes have comparable income. It's not the racial income gap. They have comparable levels of education. It's not the racial education gap. They have comparable levels of wealth. It's not the racial wealth gap. And they live on the same city block and go to the exact same school. It's not just segregation, which is a major driver of racial health inequities in this country. So what is it? What they found is that mobility gaps are the smallest in areas where there's low racial bias among white folks, where white people are less racist, and where there's high father presence in Black neighborhoods. This isn't father presence in your home. This is the presence of fathers on your city block. And so we have to ask ourselves, what's the relationship between white racism and father presence in Black neighborhoods? One example that we've seen all too many times in the recent news is what journalist Michael Carriot refers to as white collar crime, CALLER, where white folks call the police on Black folks simply for existing. We often analyze those exposures and say the person who's most at risk there is that individual who perhaps might be intimidated or harassed or suffer violence at the hands of police, or could even be arrested. But what we don't think about are the intergenerational impacts of those exposures on the children who live in those communities, who, if Black men are extracted from their communities as a result, will suffer for poorer economic mobility, not just for themselves, but as they become parents as well. So this is the pre-existing inequality that already marred our nation before COVID-19 hit. And if you look at current hotspots, this is updated just today, you can see that it maps really closely COVID-19 outbreaks to areas where our economic mobility gaps are the greatest by race and gender in this country. Overall, we know Black and Latinx populations have the highest rates of COVID cases. Among children in particular, 70% of those who have the rare outcome of that multi-inflammatory syndrome are Latinx or Black. Among Latinx children in particular, they have the highest rates of all children and youth and young adults of COVID cases and COVID deaths. Among kids aged 5 to age 29, Latinx children, youth, and young adults account for 40% of deaths. And if you were to include Black kids in that summary, among this age group, Latinx and Black kids account for 74% of COVID deaths. We also know Indigenous populations are disproportionately affected across the country. This is particularly true in states like Mississippi, where Choctaw Nation has a much higher rate of COVID-19 mortality than the local white population, or in states like New Mexico, Arizona, and Utah, where Navajo Nation has by far the highest rates of COVID-19 deaths. Overall, for the country, Indigenous Americans have a COVID-19 mortality rate that's about 3 times white Americans. Black Americans, in summary, though, have the highest mortality rate of any racial and ethnic group, just higher than Indigenous populations. So we have to ask ourselves when we see these differences, is this evidence of a disparity, which is a simple difference in health for populations, or is it evidence of an inequity, which is a difference in health for populations that are wholly preventable? And because it's preventable, it's unjust. Today, we're going to explore the extent to which these differences are actually inequities, and we should refer to them as such. So where do inequities come from? Health inequities arise when certain populations are made vulnerable. I put that in red and in bold because no racial group is innately vulnerable to these worse health outcomes. right? These are not biological or genetic differences. Groups are made vulnerable. And it often occurs through the inequitable distribution of protections to keep folks from getting sick and the inequitable distribution of supports to treat sickness and to ameliorate all of the effects of being ill, like the economic burden and toll we've seen accompanying COVID-19. At the beginning of this pandemic, we said folks who were going to have the highest risk of COVID complications and early death were people who had chronic underlying conditions like heart disease, asthma, hypertension, folks who were elderly or had advanced age, and people who lived in poverty. But what we failed to talk about, and what we absolutely have to address now, is how segregation profoundly shapes the distribution of who has heart disease in this country, or how chronic exposures to discrimination increases rates of hypertension within communities of color and Black populations in particular. How environmental racism and zoning laws shape who's exposed to pollutants and increase rates of asthma within communities of color. How the racial wealth gap profoundly determines who's poor in this country. How toxic stress or exposures, often that happen for children, but can happen throughout your life, that result in increased cortisol burden in your body, can contribute to a higher allostatic load, which weathers or silently ages your cells. When that happens, one's cellular age could actually be advanced of your chronological age, and you could be at risk for poor health outcomes from COVID-19 and other conditions at much younger ages than previously recognized. These are examples of how racism and structural racism in particular contributes to the distribution of COVID-19 in our country and in our local area. It does that by allowing differential access to goods, services, and opportunities by racial group. This is how inherited disadvantage, not just inherited disease, contributes to the risk for COVID-19 and its complications in this country. All told, it's the environment in which we all and all of our children grow, learn, work, and play that shapes not only our health, but the health of our future generations. We're going to give some examples of that just to make it more concrete. One is hand washing. Hand washing is the simplest and arguably the most important way to limit the spread of infectious disease. And yet race, not income, is the single greatest predictor of access to clean water in this country. Black and Latinx populations are twice as likely to lack access to clean water in their homes as white households. And Indigenous populations are 19 times as likely to lack access to clean water in their homes as white households. Here, structural racism is operating through residential segregation and then public divestment within communities of color that exclude them from access to water and thus access to hand washing. And this then must be understood as an exposure that shapes the distribution of COVID-19 among racial and ethnic groups in this country. Another example is air pollution. There was a study that came out in April from Harvard School of Public Health that said long-term exposure to particulate matter in the air could increase one's COVID-19 mortality rate as much as 15%. But we know, again, segregation, suburbanization, white flight, white folks moving out of areas that folks of color move into, and local zoning ordinances profoundly shape who's exposed to pollution and contribute to why African American Indigenous populations are disproportionately exposed, and thus that may also increase their COVID-19 mortality rate. We also have to change how we've been talking about age and risk for COVID. Early in the pandemic, the conventional wisdom was that we should all wear a mask to save our grandparents. And yet data came out from Harvard School of Public Health that told us that the greatest racial mortality gap by age was actually between Black Americans and white Americans aged 35 to 44. In that age group, Black Americans have a COVID-19 mortality that's 9 times that of their age-matched white peers. Again, this is evidence of what we call weathering, or what researcher Arlene Geronimus taught us is called weathering, which is how chronic discrimination can silently age and prematurely kill cells by shortening those telomeres at the end. So when we talk about risks for COVID, we can no longer just say that the risk is being elderly or having advanced age, because we are seeing high rates of mortality, particularly for communities of color, particularly for Black and Indigenous populations, much younger than age 65. So all told, what drives the inequitable risk for COVID-19 is not just poverty or underlying illness. We should never say that anymore. We have to contextualize that. And I put a star by risk to remind us again that we're thinking at the population level about systematic drivers that shape groups' risks, not at the individual level, where an individual's behavioral choices might shape their individual risk. At the population level, what's driving risk for COVID are legacies and current practices right now of racial exclusion, discrimination, disinvestment in communities of color, and violence that concentrate disadvantage in communities of color, create adversity, and shape the population level opportunity to be well and create the perfect conditions to be sick. These are why the age-adjusted all-cause mortality rate is increasing in this country, driven largely by increases for non-Hispanic Black populations, the yellow star, and non-Hispanic Indigenous populations, the gray star. But it's also driven by an increase in mortality for non-Hispanic white folks. As a result of these groups having increasing mortality, life expectancy is decreasing in the United States, and it's been decreasing since 2014. This is an aberration among any wealthy nation in the world. And it's especially an aberration in a country that spends more money on healthcare than any other. The gaps in mortality are so extreme in this country that even with the death toll of COVID-19, white mortality is still likely to be less than what Black folks have experienced in this country every single year pre-COVID. Right? You got to just sit with that for a second. What this map is showing, and it's taken from the New York Times, which adapted this map from data by researcher Elizabeth Wrigley Field. And what it shows is the dotted line is the projected jump in white mortality as a result of COVID-19. And as you can see, the top line is for Black folks in this country, and it doesn't even include their mortality rate from COVID-19. It also doesn't even include Indigenous folks or their mortality rate from COVID-19. This is how wide the gaps are in this country. And it's why researcher Elizabeth Wrigley Field said racial inequality is as deadly as COVID-19 in this country. Because as she projected in 2020, right now, in this year, white life expectancy will stay higher than Black life expectancy has ever been, despite us being in the middle of one of the most deadly pandemics our nation has seen in a century. So what are those legacies and practices of racial exclusion, discrimination, disinvestment, and violence that are driving this uneven distribution of COVID-19 in society? When we think of that legacy, we often think back to this time. We think of the Jim Crow South and segregated public accommodations like water fountains or bus depots. But we don't as often think of this time. This is a picture from Newark, New Jersey in 1967, and what historians now refer to as the long, hot summer of 1967. They call it the long, hot summer because during that summer, there were 169 race massacres across the United States, all sparked by an event of police violence against a Black taxi driver in Newark, New Jersey. When we talk about the legacy of racism in this country that shapes the distribution of chronic illness, we don't talk about what it feels like to be this little Black boy walking down your own city block with your government behind you, guns drawn, and your hands are up because you know you're not safe. What we don't talk about is what it's like to be these Black women who are lining the sidewalk, not intervening, with their hands also up because they know they're also not safe. What we don't talk about is what it's like to be this little Black boy who's on the hip of a caregiver, looking back at a boy who's just a little bit older than him, understanding something about what it means to be Black and a boy in this country. right? What we don't talk about are the ways that state-sanctioned and police violence absolutely drives the distribution of chronic disease in this country. And so we're going to talk about it today because many are asking, what has changed since then? This is a cover of Time magazine that won the Pulitzer by photographer Devin Allen that asked that question back in 2015 in Baltimore after police murdered Freddie Gray. We continue to ask that question, especially now, knowing that no one will be indicted for the murder of Breonna Taylor. So when we talk about the exposures that drive the distribution of COVID-19 in this country, we absolutely need to talk about police violence. And many doctors don't even know the connection. So we're going to make it today. What do we know about police violence? First, we know police kill about 1,000 people a year in this country. And we know police exposures are particularly deadly for Black men and boys, of whom the National Academy of Sciences told us just last year, 1 in 1,000 will be killed by police in their lifetime. I always tell this figure to pediatricians because 1 in 1,000 is also the mortality rate of measles. When you think of the near constant public health surveillance and public health funding we put into eradicating measles, and you compare it to the relatively little our own health institutions are doing to address the deadly exposure of police violence, you see how racism not only shapes who's exposed to deadly exposures, but it also shapes our response in healthcare and in public health. So let's talk about California, because we're lucky to live in a state for whom data around police use of force is openly available. This data was brought to us by our Attorney General, Kamala Harris, when she was our Attorney General, now our Senator, and also obviously on the presidential ticket with Joe Biden. So what we know is that when police use force, although death is what's commonly covered in the media, it only happens about 1 out of 5 times in 2019. What was much more common and happened almost 2 out of 3 times is somebody suffers a serious bodily injury. So then you have to ask, well, why did police come to the scene in the first place when they used force? In our state, just last year, more than half of the time that police came, they came because somebody called for help. Just think about that. Somebody calls for help and the police use force, and 1 out of 5 times somebody's going to die. And almost 2 out of 3, somebody's going to suffer a serious bodily injury. This is why we are having a crisis in this country around what we call public safety, and why many advocates are saying you can no longer call this institution one that keeps us all safe in the same ways. Recognizing that, we're also fortunate to live in a state that has passed the Crisis Act that will now, over the next few weeks, be placed on Governor Newsom's desk. The Crisis Act, or AB 2054, is a pilot program that would fund community-based responses so that people don't have to call the police when you're in crisis, particularly if your emergency is related to being unhoused, having a mental health crisis, intimate partner violence or community violence, substance use disorder, or natural or climate disasters. There is concern among advocates that Gavin Newsom is going to veto this bill that had broad bipartisan support and has the funding already outlined. So for folks who are looking for things that you can do already, call Gavin Newsom's office and please let him know that you as a doctor absolutely support the Crisis Act. What else do we know about exposures to police violence? We know victims are at risk, as we've talked about, for death, injury, disability, as happened with Mr. Jacob Blake, mental health impairment, and all of the adverse health consequences associated with arrest and incarceration. But we also know witnesses are affected. And this is looking just at teens who witness violence. They have increased rates of poor mental health, things like PTSD, substance abuse, depression. They also have poor reported physical health and school failure. School failure is a major indicator for worse long-term income. It decreases one's earning potential. It's a major indicator for early introduction into our criminal justice system in this country, and it shapes your life expectancy. So it is no small thing that kids who witness violence have higher rates of school failure. We also know that some kids' exposure to police is shaped by their immigration status. For kids who experience or witness the immigration-related arrest of a family member, they also have higher rates of depressive symptoms, and those symptoms are magnified if both of their parents have undocumented status. We know that police violence is also a form of community violence and a form of gun violence, that all those who fight against community violence and gun violence also have to start to address. Because living in neighborhoods in which police kill folks increases rates of hypertension and obesity, particularly for women who also live in those neighborhoods. And remember, hypertension and obesity are two of those conditions that we've said are underlying conditions that contributes to you having complications from COVID. For kids, police exposure and police violence might be experienced as caregiver absence. If your caregiver is killed, hospitalized, or incarcerated as a result of their interaction with police. It can be experienced as a custody transition or as their own criminalization or the criminalization of their peers, which we saw with that little boy in New York with his hands up. We have to then think about how that transforms even routine police encounters, even ones where no violence happens, to encounters where that trigger for children these other profoundly traumatic experiences associated with loss and stress. And so either in quantity, the number of those encounters they have, or severity, if those encounters result in violence or the separation from a caregiver, also affects children's health. We also know that parents who are imprisoned, their kids have higher rates of chronic illnesses, from physical illnesses like headaches and asthma to mental health impairments. Families who have a parent who's imprisoned don't have equal access to employment, public housing. Sometimes they don't qualify for student loans, so they can't go to school and get higher education. And there are states for whom having a felony still disenfranchises folks, which, as we come up to this upcoming election, is a critical barrier to people participating in our democracy. We know that children who are detained at our borders also have increased rates of mental health impairments and developmental delays. Those behavioral changes could manifest in changes in sleeping habits or impaired school performance, which again is a major indicator of their future health as an adult. So overall, racism is a devastating root of chronic, undertreated disease and completely preventable premature death in this country. In short, racism kills people. But we know equality saves people's lives. Because equality saves people's lives, because equal access to resources economically, socially, politically, saves people's lives and narrows racial health inequities, I have been saying since the beginning of this, that protest is a powerful and vital public health intervention. I even wrote an article in Cosmo trying to say that to young people to encourage them, because the constitutionally protected right to protest is critical. It is what has gained just enormous improvements in civil rights for folks, and that is crucial to protecting people's health. And yet, we're not all protesting for the same thing in this country. This is a picture from Texas on June 30th, 2020, after Texas had a record peak in cases of COVID-19, the governor closed bars. But Texas wasn't alone. Throughout this pandemic, we have seen white folks take to state houses across the country, protesting everything from the closure of their businesses to having to wear masks. And so we have to ask ourselves, what is the relationship between whiteness and risks, health risks? We don't often talk about whiteness in medicine, but I think it's really critical to talk about. And so I'm going to give you some terms so that you can talk about it. And we're going to go through how it might be related to risk for COVID-19. Too often, when we don't talk about whiteness, it becomes normative, even though it is absolutely shaping all of our worlds and who has resources and who doesn't. So what is whiteness? It's not the same as white. So white is a racial status, which is phenotypically determined, right? It's affixed to what one's skin tone is. Whiteness, though, is a structural apparatus. Whiteness is structural. It is the systems and policies and practices that then can confer advantages or privileges to white folks as a population. It does that, again, through laws and norms. And it works at the population level, not the individual level. So I put here a picture of somebody getting a boost over a wall. I included that because individual white folks absolutely face hardships in their lives. But how whiteness works as a structure is to provide a boost over some of those hardships because their racial status may give them a privilege that other groups and groups of color don't have. What's an example of that? An example would be that we know that Black folks, for example, have less wealth for every level of income than white folks. When compared to white folks, Black folks have lower levels of employment at every level of education, right? There are barriers that groups of color cannot surmount because of racism, discrimination, and exclusion that keep them from surmounting certain hardships that white folks can sometimes, through systematic advantages, surmount. So when we're talking about whiteness, we're talking specifically about certain kinds of racial exclusion and discrimination. We're going to go through 4: white hegemony, white supremacy, white privilege, and white normativity. White hegemony are the forms of racial exclusion and discrimination that establish and enforce racial hierarchies in which white people nearly exclusively hold decision-making power. Think about your own practice or the hospital where you work. If you are like 91% of healthcare institutions, you are likely led by a white leader. White supremacy. This is a form of racial exclusion and discrimination that creates and maintains a racial ordering of humans and resources that reinforces the racial dominance of whites. White supremacy makes it seem like white folks are better because they have more and have more power. White privilege is a form of racial exclusion and discrimination that preferences white folks through disproportionate access to resources associated with mobility. And we talked about the profound mobility gaps we have in this country. And white normativity is a form of racial exclusion and discrimination that naturalizes power asymmetries between white and non-white people as primarily meritocratic. This is when we say that the reason we have so many white folks in leadership, or the reason so many white folks hold power over others, is because they deserve it more, because their CV is stronger, because we value their contributions more than other groups. And Jonathan Metzon's Dying of Whiteness, which came out last year, which in full disclosure, I reviewed for The Lancet just in January of this year, he makes a really compelling and poignant argument that whiteness as a structuring principle can also, because of the racism it engenders at a population level, it can also harm and sometimes even kill white folks too. For example, if white folks vote for policies that take resources away from public institutions that they also rely on, like schools or healthcare, because they don't want folks of color to access it, they also don't have it. So this is a book I would highly recommend for people who want to learn more about how whiteness works and its relationship to health. Overall, and we'll close here and open up for questions, I want to go through what we can do about this. So to adequately respond at scale to racism as the public health crisis that it absolutely is, we as a field have to move towards abolition, which is also something we don't talk enough about. So we're going to talk about 4 ways that we could work to abolish racism. We're going to start with truth and reconciliation and reparations. In my field, pediatrics, we just back in July, the American Academy of Pediatrics acknowledge, through an effort towards truth and reconciliation, the time in which we as a professional society excluded Black pediatricians, who were the first non-white pediatricians who attempted to join. Why that acknowledgement was really critical, what it lacked was a reparatory framework for what pediatrics, the AAP, is going to do about it. In the words of one of our most prominent national pediatricians, Dr. Mona Hanna-Attisha, who taught us all about the Flint water crisis, surviving life's hardest blows shouldn't be celebrated or even expected. Recovery and reconciliation require reparations and actual resources. If we just expect resilience from folks without actually giving them justice, it really is just indifferently accepting the status quo. So whenever we talk about truth and reconciliation, the point of that is to acknowledge specific ways in which you've harmed populations, and the AAP did a wonderful job of doing that. And then the next step is to move to address it. And I know that they're working on that, but these three always have to go together. Next, one form of reparations absolutely should be wealth redistribution. Why? Because we know so much has been taken from Black folks and other communities that have suffered oppression because of racism. And as a result of that, we know the wealth gap in this country is enormous. For example, for every dollar of wealth held by a household with white children, households with Black children have one single penny. One way we could creatively think about redistributing wealth is reinvesting our public resources away from punitive interventions like the police and into a caring economy. This includes the healthcare economy, but it's much broader. It also includes paying for with our public resources and maybe even with Medicaid, which we can talk more about this for folks who are interested because one of the projects I work on is trying to do this in California, but paying for caregivers to care for the populations under their care, paying for parents to be home and to be a behavioral health intervention for kids, paying for peers to be a mental health intervention for teens. This is an important way to invite folks who have traditionally been excluded from our workforce into the caring economy that we so richly fund as the country who pays more for healthcare than any other. We also need to strengthen our safety net systems. You know, Missouri was the last state to expand Medicaid. Every single state should expand it. We obviously need to invest in public education. The pandemic has made that so clear. Hunger has increased. Close to 1 in 8 households are now food insecure just since the pandemic alone. So we also need increased access to food programs, both at food banks and through SNAP, the food stamps program. We need to broadly expand public goods. While expanding Medicaid is useful so everyone has insurance, insurance is still a barrier that racially tiers healthcare. It tiers the quality of care you receive and the setting in which you receive it. So we need universal healthcare to get rid of insurance as a barrier. We need universal basic income. We're fortunate to live in a state that has a pilot of universal basic income in Stockton, and I'm fortunate to live in a city, San Francisco, that's piloting universal basic income for Black mothers for 6 months after their delivery to try to close maternal mortality gaps. We also, as a Bay Area, and you guys as Santa Clara County, I think should be the first pilot of universal internet at a time when we know everybody needs to learn, receive their health care, and work remotely. All in all, we have to move to abolish racism from every institution, every practice, every policy, and every social norm in which it operates and often is hiding. The future health and well-being of our kids and our kids' kids are absolutely going to depend on how we do this. I want to run through this because I think this is really important. These are our last 2 slides. There are already frameworks to help us understand how to move forward. One is equality. Universal healthcare is one example of that. We could just offer everybody the same thing. But as you can see from the diagram here, or the picture, even offering universal healthcare will not get rid of the barriers that some people face to receiving care. During COVID-19, one example that would be an equitable response would be to target a universal approach within a specific community. So, for example, like offering COVID-19 testing in areas that are affected by segregation, because you know segregation shapes the risk for chronic underlying illness. But even that doesn't actually get rid of folks who are disproportionately exposed. So what would liberation look like? Getting rid of those disproportionate exposures. One of those could look like mandated worker protections so that everybody has paid sick leave, hazard pay, parental leave when your kids get sick. Those type of things enable people to take the precautions they need to keep themselves and the people that they love and care for well. And the last thing that I've been promoting, because I think it's absolutely critical, is that we start thinking about what it means to change our caring system in healthcare to a system that actually loves people. And one thing Dr. Russell and I have even discussed is what it would mean to then share PPE, even in the middle of a pandemic, even when PPE is limited in supply in our healthcare facilities, sharing it with other essential workers who don't have the same access to PPE that we have in healthcare is an anti-racist intervention, because our workforce is predominantly white at every level, and the essential workforce is predominantly folks of color and mostly women of color. And so if we keep the lion's share of our nation's PPE, we are contributing to racial health inequities in our society. And so what love would mean is we would share it, even though we also have that need. I think love has to become a metric by which we measure our system's performance, by which we measure the efficacy of the delivery structures that we create and the impact of the care that we're hoping to provide. But the most important thing that I probably will say today is this one. Every single one of us as a doctor, if we care about health equity and we care about addressing racism, has to vote in this upcoming election. I think maintaining our hope is really the most important thing. This is a quote from Brian Stevenson, our national treasure and founder of the Equal Justice Initiative. As he says, hope is our superpower. Don't let anybody or anything make you hopeless. Hope is the enemy of injustice. Hope is what will get us to stand up, even when they take the mailboxes and make it so hard to vote. We have to do it. So thank you for inviting me. I'm so interested to hear everyone's questions.
All right, let's see what we have. Okay, we have, thank you so much, Dr. Boyd. That was just an outstanding talk. I think if we were in a room with people present, I think everybody would really be speechless. It's so compelling, so well researched, and it really changes hearts and minds. I've heard you speak before, and it was as good and maybe better than the last time. So thank you so much. It's just outstanding. We do have a question. We'll start with questions now. This is a question from Jake Tonkel. He asks, how do we provide reparations and move toward caring economy that doesn't perpetuate the capitalization of work for the sake of the GDP, especially in healthcare? It's a good question.
This is a good question. Thank you for this question, Jake. You know, it can be complicated. I think I am absolutely a proponent of the federal government doling out reparations in the form of actual just checks to the descendants of enslaved Africans who worked without being paid and created the wealth that this country is based on. That said, I think individual institutions also can take on what reparations looks like. I think one good example that I've sometimes used is like Georgetown. Georgetown said, listen, this university was built by enslaved families. We know exactly who those families are. We know who their descendants are. And we are going to openly acknowledge Truth and Reconciliation that we have harmed those families. And then we're going to move towards reparations and allow the descendants of those families to have scholarships to attend Georgetown for free and to have a special admissions program. So I think one way to think of reparations is to break it down from, we can think about what the government owes certain groups, but we can also think specifically about what our institutions owe people to allow them to participate in hopefully what will be a caring economy. If we had universal healthcare, I think it wouldn't be as capitalist as healthcare is now. And hopefully that would also shift some of the profit incentives, but it would also provide the endless resources of all of our public investments into our workforce, and then inviting other folks in, you know, would be honestly more socialist. Oh, I think you're on mute, Dr. Russell.
Yes, we have another question from Alicia Toussaint, and she asks, are there any interventions you would recommend for the addiction to incarceration in this country and the poor conditions suffered by prisoners? Certainly a large public health problem suffered by most POC.
Yeah, I mean, I think abolition. I am reading more and more about what it means to abolish prisons and abolish jails. I have to thank my own kind of coming to consciousness around this. I have to thank, you know, Angela Davis and Ruth Wilson Gilmore, scholars, activists, abolitionists who first framed the question, you know, decades ago. I mean, you know, Angela Davis back in the 60s, like, what is the role of prisons in society? And what do we concede when we allow prisons to continue to exist? And if we organized and had our systems transformation kind of rooted in understanding a society where prisons don't need to exist, what would our institutions look like? So when I say move towards abolition, that doesn't mean I think we should just erase all the prisons immediately. This will have to be a process. But it does mean I think we have to build from a place where we say, to the other person's comment, like, incarceration is a moneymaker, that this is a part of our capitalist society, that we imprison and punish people and torture them in that way. And it's bad for people's health. So if we can start from the point of, what if this didn't exist? What institutions would we need so that it wouldn't have to exist? And then we build those up and invest in those. I think that's how we move towards decreasing our reliance on them.
Yeah, that's excellent. And I wanted to say I'm finishing a book called Just Mercy. I don't know if you've had a chance to read it, but and it is just a lovely book. I would recommend it to everyone. It's sad, it's compelling, it's extremely well written, and I would recommend it highly. All right, we have, all right, here's another question. How far are we from universal health care, and how might that change the profession for physicians, and how can physicians better advocate for it? That's another good question.
Yes, good question. I'll also say Just Mercy is authored by Brian Stevenson on the last slide, and I shared the PDF if people want these slides as well. How far are we from universal healthcare? Gosh, I hope not far. I hope we are one election away from universal healthcare. I am grateful to Bernie Sanders and all of the folks who have been advocating for universal healthcare, for decades at this point. I think we have I think their work has pushed the Biden administration, at least, to be considering the pathway to universal healthcare, which was not how he came into this campaign. So I hope we're not far from universal healthcare. I think it may change who wants to become a doctor, because it may not be as lucrative a profession as it was before. But I think that's all to the good, honestly, if we continue to just reinvest those resources that used to go to clinician salaries and executive salaries back into communities. I mean, that would keep people well, so they don't even have to see us.
Yes, and I think Christina Minor, she also mentioned, I'm pro-universal healthcare, but not pro-Medicare for all as a payer. As an anesthesiologist, we're already only receiving 33% of other specialties for Medicare reimbursement. It would be unsustainable. It was otherwise. So it's her comment. And all right, we have another comment. We're getting a lot of comments here. So we have a question from Dr. Robert Gould. Hi, Robert. Good to talk. Good you're here. It was a really great presentation. What a privilege to hear you, Dr. Boyd. Is all the Q&A? Okay, no, we can go ahead and unmute. I just don't know how to do it. I don't know on my end. Samira, can you unmute Dr. Gould? Or can I? Let's see. He has to unmute himself now, I guess. I think you can unmute now.
Can you hear me?
Yes, we can hear you now.
Oh, I didn't know what the format was, and I didn't want to jam you up for time or anything like that. Anyway, I want to really express my great appreciation for you and your work, Dr. Boyd. Some people who are on the call know of work that I'm doing. I work with Physicians for Social Responsibility, and we and many other organizations are, trying to come to grips with many of the things that you've been talking about in terms of our work, the way we structure ourselves as well. So it's a very welcome how you've put together all your work. And just at a personal level, recently took a week's intensive course that was offered by Kimberly Crenshaw and her colleagues on critical race theory, which certainly underscore so much of what you've said here. So my question was more general in terms of what your hit would be on, if we're lucky, as I said, lucky to have regime change come November or however long it will take to see that. What your hopes or thoughts about the possibilities of a Green New Deal that could help unlock a lot of the things that you're appropriately calling for?
Yes, thank you for that question. And it's so exciting that you got to learn from Dr. Crenshaw. Um, I think the Green New Deal is really critical. I think it's also, in some ways, an anti-racist approach to the ways that, climate catastrophe um, really preys on communities that are already divested in, that are already made vulnerable. So communities of color, honestly, worldwide, are the ones that are going to face the brunt of our shifting and disastrous climate. So I think the Green New Deal is really critical to that. In that regard, two of my colleagues and I, Nancy Krieger from Harvard School of Public Health, and Kamara Jones, who I believe she just was at Radcliffe, but I think now she's at Morehouse School of Medicine, and I are writing an article in The Lancet on that very topic. What are the relationships? It's not that exact same topic, but it includes what are the relationships between environmental racism and what are paths forward. We don't name the Green New Deal explicitly because they asked us not to, but we're for it.
All right, and that was excellent. Thank you. Dr. Sidhu has a question. She appreciates the information, and she wants you to comment on policies that we need to have in place to create a robust safety net.
Gosh, that's a really good question. I think some of the things that we need to do to have a more robust safety net is just pour more money into it. I think our safety net is so chronically defunded that it's hard, for it to really respond to folks' needs in the ways that it should. And I think that's only been made more clear during this pandemic. If we had really robust safety net structures that the whole country could lean against right now, as everybody needs access to COVID testing, as everybody needs, access to learning at home and internet, like if we had a more robust safety net structure, I think we would fare better right now. I think one of the number one things we need is more funding for it. I know we won't get a full time to talk through this whole thing. I also wrote on the safety net in a piece in The Nation. I've only written really 2 pieces in The Nation. So if you search Rhea Boyd and The Nation, you can see more of how I outline what I think it would take for us to make a more robust safety net. Thank you for that question.
All right, and I'm going to move along to Dr. Balakrishnan. She says, excellent speech, this should be heard nationwide, and she wonders about financial equity and how to do that.
I think reparations would go a long way in terms of narrowing some of the gaps that have existed that really there's no other way to surmount. That intergenerational wealth is what people are lacking, and you can't really close that even if we did close, for example, like the pay gap, which just in healthcare alone among doctors is really wide. Like the biggest pay gap is between white clinicians and white male clinicians and Black female clinicians, and it's as much as $200,000, even if you hold constant where they work, their experience level, and what their specialty is. So I think, one, we could just pay people fairly and try to close the pay gap, but reparations by far, I think, will be the most important thing, because people have lacked adequate resources for centuries now, and had their resources, frankly, just stolen from them. There have been a number of recent proposals for how we could do that, maybe even starting with kids, that as a pediatrician I'm interested in. Some of those include just futures funds and baby bonds, which are plans that the government creates, like bonds or like bank accounts the government opens for every baby, and it puts $1,000 in for you every year. And then after you're 18, it's like a trust that then you can take out and enjoy all of the interest on. It relies on the market, which is the downside of it, but it could maybe help close a tiny bit of the gaps.
Yeah, that's excellent. And I think there are some countries in Europe that do, have some of those safety nets as well. We have another question by Dr. Hairston. Now, Dr. Hairston was our speaker for our first series, our first webinar, and she has a question. I don't know if she wants to answer live or not. I don't know how to do that if you do, but her question is, Can you discuss the impact of racism on children's health? Frequently, we hear racism discussed in medicine as if it's a thing of the past. How is it affecting our children now, especially what they're seeing in the media?
Excellent question. It's such an honor to follow you, Dr. Hairston. So racism absolutely affects kids. It affects kids directly. Kids are treated differently as a result of their perceived racial grouping. It affects kids vicariously. This is the work of Nia Hurd-Garris from Northwestern. Meaning if kids witness, like what you're saying about what kids see in the media, when kids witness other people who are treated unfairly, discriminated against, suffer violence as a result of their status, racial status, kids internalize that and come to understand it as a indicator of their own safety, security, well-being, and future prospects. So I think it's super important to talk about kids and racism. I'll give like two quick examples, even from the medical literature. I mean, there was just that really devastating study, two devastating studies, one that looked in surgical specialties that looked at a national database of surgeries, and it looked at outcomes, morbidity and mortality, and it found that Black kids who are well, this was only looking at healthy kids. Among healthy kids, Black kids have a mortality rate from having surgery in this country that's 3 times more than white kids. I mean, the gap was enormous. It was really scary because these are otherwise healthy kids. And unfortunately, the study, because it was in this national database, couldn't tell us which hospitals and which procedures put kids most at risk. But you have concerns that kids also receive segregated care. They also receive care that's lower in quality based on their racial status, based on their insurance status. So that was really devastating. And then that other study that came out in PNAS, the Proceedings of the National Academy of Sciences, which told us that, Black newborns, it was the racial concordance study, that Black newborns who are cared for by white clinicians, if they were cared for by Black clinicians, would decrease their mortality rate by like half. That was also a very devastating study that's really rocked pediatrics. So kids are absolutely affected by racism. Thank you for that question.
Can I jump in with just a follow-up? So thank you, Dr. Boyd. With that, if we move to a universal healthcare system, what types of other additions to our healthcare model do we need to have so that you address that racism in care that our Black and brown communities will get?
Great question. Segregation. We have to address that people receive their care in segregated facilities. This is also true for the maternal mortality rate. Like that bombshell report that came out of ProPublica, I think 2 years ago, that told us in New York, because the national maternal mortality rate is like 3 to 4 times higher than maternal mortality for Black versus white. And in New York, in some hospitals, it was like 7 times. It was double the national rate despite that huge gap. And what they found is that those were women who delivered and had their perinatal care in facilities where upwards of 80% of the patients were also Black, which at first you would think, well, you care for a population and you think you would know how to care for them. But what it really exposes is that people receive segregated care. And when our care is segregated, the quality is lower. Segregated is not equal, And so I think we would have to attack segregation. We would have to make sure that people have access to every health facility that exists, which the real question would be, how would we then keep folks from resegregating it? The same way we see white flight happening in communities that integrate or desegregate. When folks of color come in, white folks move out. If we would try to desegregate healthcare, one of my concerns is that white folks would try to create other areas where they receive their care. The same thing is also happening in education right now with schools resegregating post Brown v. Board, which was 1954. It was so long ago, and yet schools have resegregated, not because of the movements of Black families or Latinx families, but because of the moves of white families to ensure that their kids go to schools that are predominantly white. So I think if we had a way of attacking segregation, and I think tying it to federal funding for healthcare facilities would be really useful to close those gaps.
Wonderful. We have several more questions. One was from a bit ago. How do we educate our patients, ourselves, and our colleagues and community about the risks that come with race?
Yes. Read. We have to read way more. There is centuries of research on this. This isn't new. Nothing that I'm saying, I didn't even make it up. You know, I tried to put references in here so that everyone could see, but the first person who probably said that racism kills people was W.E.B. Du Bois in the Philadelphia Negro, which is at the beginning of the 19th century. So we've known this for like centuries, and I think we just have to read it more. So the first place to start is to get some good books. Ones that I have found helpful are Medical Apartheid, so that you can know the history of experimentation and racism that has existed within healthcare. Killing the Black Body by Medical Apartheid's by Harriet A. Washington. Killing the Black Body by Dorothy Roberts, which looks specifically at maternal mortality rates. Sorry, I'm just looking at my own bookshelf really quick. The Racecraft, I find, is an excellent book about how race gets remade. The Push Out, for people who are concerned about the school to prison pipeline in kids and how kids experience racism in their own schools. The Push Out's by Monique Morris. Gosh, there's so many books. Just, you know, we all just got to start reading.
All right, great. And we have another, it's kind of a related question. Let's see. We have so many questions. So here it is. Thoughts on how, this is Dr. Sutherland, thoughts on how we help our African-American children understand and deal with the racial injustices occurring today, George Floyd, Breonna Taylor, etc.
Yes, this question just really, you know, it really gets to you because kids know. And we know that kids' racial socialization, where they come to understand their racial identity, happens as young as age 3. So we're talking preschoolers. Parents need to be talking to them. I think Black parents, because they also know, because they also grew up, know how to have that conversation with their kids, or at least they practice and have tried to have that conversation. I think it may be harder for white parents who have adopted kids who are kids of color or who want to talk to their own white kids about racism to open up that conversation, usually because they think their kids are either too young. Again, kids know as young as age 3, or because they think what's happening is too egregious. One thing that I love that the Nia Hurd-Garris, that wonderful pediatrician from the American Academy of Pediatrics, did is participated in CNN's special with Sesame Street, where Elmo had the conversation with his dad, Louis, and it was really beautiful. And basically Louis's dad said, you know, not every street is like Sesame Street. And Elmo came to understand that racism hurts people. And so then they went to their community center at the end and they made signs and they went to a protest, and it was really beautiful. So that may be a perfect mirror of the type of conversation you can have, where all of the details need not be there. But what you're doing is you're affirming for kids that what they are witnessing is happening, but that you as the adult or as the caregiver or as the clinician in their life are doing things to keep them safe. And there are also things that they can do to keep their peers safe, so that kids also think about how they're standing up for their own peers.
All right, excellent. And we do have a request, Dr. Boyd, that you share a list with us afterwards of your books, your favorite books recommended. So we have Carol Somerville has raised her hand, and I don't know if Samira can help with that. Can you unmute, Carol?
Excuse me, that must have been a mistake. I did not raise my hand. Thank you.
Okay, all right. And we go on to a next question. There are certainly some that are pretty hard hitting. We'll go with this one first. So what's the best strategy for influencing colleagues who don't see this as a problem because their panels don't have many POCs?
You know, the short truth is, I don't know. I think I have tried to learn how to continue to teach this better. And I think I try to teach it in as many forums as people invite me to. I think hosting forums like this is useful because it validates and legitimizes this as an important part of the care that we provide. So if you have the power, inviting grand round speakers, creating CME activities, all of that I think is really important. Colleagues and I are working to create more robust like licensure activities for pediatricians in particular, so that when you have to do board questions, that some of the questions that come up are about racism and health. So I think institutionalizing it as something that everybody has to learn is maybe the way that some people might access it if their own interest or practice doesn't lead them there.
All right, excellent. And another question, what are the relationships between trade and supply chain globalization and racism around the globe? How can corporate America manage this to counter racism?
Whoa, that one is huge. I mean, I don't know if I can answer it fully, but I have also come to understand that the ways we talk about structural racism can sometimes be lacking because it misses the way that capitalism and racism are co-constitutive, like they make up each other. You can't have capitalism, which tries to order who has resources, without having racism, which is the most durable and efficient way to order who gets things in society. So the two always go together. And so if you want to actually have an anti-racist practice, you have to link it to an anti-capitalist practice, which is also why, without saying it's anti-capitalist, I say, you know, we need more robust public goods. We need to invest in safety nets because those are collective institutions that all of our resources go into and everybody can, you know, exact the benefits of. So that's how I often approach it, because I know talking about capitalism maybe is a touchy subject for people.
Yeah, and here's another question. Dr. Boyd, how have you thought about incorporating social and racial justice into medical school curricula?
Right when I left residency, I taught residents at Stanford in their pediatric program, and then medical students at Stanford this topic, because at least for pediatrics, and I think it may be true for internal medicine as well, there's a community block. There's a block where you are trying to learn more about social determinants of health. And I think these topics fit perfectly into there. So inviting lecturers in and having experiences where like journal clubs and experiences with the community where residents and trainees could actually start to think about these topics, medical students as well. That's the way that I've tried to approach it. And it's usually as being like a adjunct faculty like I am at Stanford, or like an invited speaker. But again, we need to institutionalize it. So it should just be a requirement where everybody has to learn about it. And so if you have the power to make that a requirement, like, please do so.
Great. Here's another one. Well, it's a bit of a hard question. It's a direct question. Is the incompetent and dysfunctional federal response to COVID-19 really a form of racism opposed to any other reason or excuse? Dr. Goldberg.
Great question. You know, I think it's multifactorial, and I'm not trying to say it's only racism, but I also think that there is a relationship between what looks like ineffective government and what is actually incredibly effective structural racism, right? What does it mean if you divest from public institutions that are predominantly protecting communities that are otherwise made vulnerable? What that means is that the impact of that is that you're disproportionately, you know, harming folks of color. Like, that is structural racism. So even if the surface of that may look like just abject incompetence, the actual impact of that has been an incredibly effective way to hamper and almost completely dismantle our public health infrastructure in the middle of a pandemic that's claiming folks of color's lives above other groups. Like, everybody has died, but obviously we've reviewed the disproportionality there, right? Like, what is the impact of calling for quote unquote law and order, as just happened after, you know, there's no indictment for Breonna Gray? Like, though, that's not incompetence. It's actually an incredibly sophisticated way to say that certain people should be protected by the law, the police in this case, and certain people shouldn't, Breonna Taylor in this case. Like, so I would actually question how much is true incompetence and how much has been an incredibly effective tenure of a president that openly supports white supremacists and has policies that have a devastating racially disparate impact.
Right, and I think we have another one. It's you know, basically it's another question that's related to that. How do the proposed solutions that you presented become real when you have systemic racism and racist constructionists at the highest levels of government continuously counter any progress in human rights advancement with devastating covert policies that regress any advancement? So, yeah.
Exactly.
It
It's
is.
why this election is critical. It's why I ended with vote. I now talk to everybody. I'm even talking to a high school class coming up. Like, I am talking to everybody who invites me, and I'm ending these lectures with saying, we have to vote up and down the block, but the presidential election, up and down the ballot, but the presidential election is critical because all of the resources that so many communities need are on the ballot right now. The census, like, we are talking about putting in motion the census, the courts, the planet, we are talking about putting in motion things that we may not be able to walk back from. So I hope everyone's voting and helping other folks around them vote.
Great. And I have another question, getting a little low on time, but you mentioned in an article the disconnect between medicine and public health and training, and this has to do with social determinants of health. And what do you think public health, how should they be, changing their focus? What do you suggest to really look at social determinants of health? And have you seen change in this?
I would say public health is maybe further along than medicine is. I think, the APHA, the American Public Health Association, came out first in 1995 and said that police violence was a threat to public health. And they reaffirmed that statement in 2018. Public health has contributed to some of the data that we've used to demonstrate the devastating toll of racism on people's lives. Like, that didn't come from clinical scientists. It came from folks who work in public health and the social sciences. So in some ways, I think public health can lead us. I think we're in the middle of, an administration that is been incredibly hostile to scientists and public health officials. And I think that has made it hard for us to kind of link up with public health and be really effective. And that's devastating that that's happening in the middle of a pandemic. But I think there's something about, I guess I'm saying that because I think there's something about this current political moment that makes public health seem ineffective, both because it's been demeaned and defunded and kind of muzzled, and because the pandemic is just completely out of control. But I think public health overall has a very effective approach to addressing social determinants, or at least is further along than we have been in medicine in doing that.
Great. And I think I'm just going to ask you just one more question. I think you might be aware of administrations saying that it would divest, or rather defund schools who are trying to teach the 1619 project by K-12 schools. And of course, education is really important in diversity and inclusion training. What's your response to this?
Yes. The question about how do we get people to understand, I think begins when they're much younger, because kids already start to process as young as preschool age what race means and what racism can look and feel like. We also have to offer kids tools to understand the historical context in which their own experiences live in this country. And unfortunately, during this administration, and honestly throughout this country's history, we have not done that effectively. We don't teach the founding of this country from its relationship to slavery and indigenous genocide and dispossession. Many kids learn, and I learned, Columbus Day. And we have to sit with that, because right now, luckily, we have something like 1619 Project that could offer kids a way to understand and contextualize their own experiences with racism. But again, people don't want that to happen. I think challenging and whenever we can advocating for our kids to be able to understand this just as much as we advocate for it to be a part of our CME as doctors who have more education than, most of the population, I think is really critical. We don't know it as doctors because nobody made us learn it when we were in first grade and in high school and taking AP exams and trying to qualify for college and then trying to get into grad school. Nobody made us know this. And one of the things my co-authors and I said in Stoll and Brett's in New England Journal is that we have to make people know this. It should be a professional competency. By the time you get to try to be a doctor, if you don't know this, you're not ready to be a clinician. And if you want to be a leader in medicine, if you don't know this, you shouldn't even be considered. And I mean that very strongly. I think we have to make it a competency that everyone has to have, and then we have to try to provide it at every level of education.
Yeah, that's wonderful. Thank you so much, Dr. Boyd. We are now at the end of our discussion here, and I want to thank you again for this just amazing discussion and talk and all of your work. I want to also express my appreciation to the Bay Area Medical Society Coalition for co-sponsoring this series. And this includes Alameda and Contra Costa Medical Association, the Mendocino Lake County Medical Association, or Society, I'm sorry, Monterey County Medical Society, the San Francisco Marin Medical Society, the San Mateo County Medical Association, the Santa Cruz County Medical Society, the Sonoma County Medical Association, and the Solano Napa County Medical Society. So this was just terrific. This will be recorded and will be on our website. And I do want to remind everyone also that a surveys will be emailed to you shortly, and you're going to receive a CME certificate and certificate of attendance upon a submission of the survey. And if you have any questions at all, you can email Samira at sccma.org. And I think Samira is going to post her email contact right in the chat box. And this concludes the 4-part diversity and inclusion webinar series. And I want to thank you again. It feels hard to actually leave this conversation. It feels like this could go on for a long time. Thank you again, Dr. Boyd, so very much for all your work.
Thank you so much for having me. Have a good night, everyone.
Thank you, you too.
Bye.